Hello, everyone. My name is Vadim Koshkin. I'm a medical oncologist focused in GU, the University of California, San Francisco. Today here I have with me Dr. Tom Hope, who's my colleague in nuclear medicine, also at the University of California, San Francisco, and Dr. Jérémie Calais, who's at the University of California, Los Angeles. We will be discussing the recently published study comparing bone scans and PSMA PET scans for the staging of prostate cancer patients. PSMA is, of course, a newer imaging modality, one that we have started using widely now for the staging of prostate cancer. It is approved for the staging of both primary disease and also recurrent disease. But most clinical trials to date and most therapies really use are based on trials where conventional imaging was used for staging. Yet now, increasingly, we, at least at academic centers, we use PSMA imaging. So what are the implications of this? And so maybe we'll start with that, and I'll have Dr. Calais maybe have you compare the sensitivity as well as the accuracy of conventional scans versus the PSMA PET scans in prostate cancer.
Yes, sure. I can talk about that. Thanks for having me here. A pleasure. During the past 5 or even 7, 8 years, there were a lot of studies reporting on the diagnostic accuracy of PSMA PET, a lot of head-to-head comparison studies showing the superior diagnostic accuracy, both for sensitivity and specificity, over conventional imaging, which means CT and bone scan. That's what we're talking about here, for the detection of metastasis, whether they're lymph nodes or bone metastasis. So on the CT, you need an increase of size, which takes times to occur, whereas with PSMA PET, you see the signal even if a very tiny lymph node. So that's how you explain the increased sensitivity. On the bone scan, here it's more problem of specificity. Bone scan just showed the turnover of the bone remodeling. So anything that would increase the bone remodeling would light up on a bone scan, which can be a bone metastasis, but which can be many things else. And so PSMA PET here, you image directly the tumor cells expressing the PSMA targets. And so that's why it's more specific. And again, it usually appears before the CT changes, the sclerosis on CT. Often you see a lesion light up on a PSMA PET scan in a completely normal bone on CT. And I think the best study that compare conventional imaging, CT and bone scan versus PSMA PET so far was the PRO-PSMA study. It's a prospective trial randomized from Australia, about a few hundreds of patients compared. And clearly the superiority of PSMA PET was clearly demonstrated both for sensitivity, but also for specificity over CT and bone scan.
Yeah, great. Well, that's a great summary. Dr. Hope, maybe you can comment on how generalizable the results are from current trials, which are based on basically conventional imaging, to our current clinical practice where we're using PSMA scans for many patients.
Yeah, I think I'll step back and we spent 5 years worrying about stage migration, right? We were all worried about upstaging of patients. You use a PSMA PET, you see more disease, right? And we're in tumor board talking about a patient who's newly diagnosed, they have 5 bone mets, and you'd say, hey, well, these trials said 3 or fewer on bone scan is going to be something you can treat with pelvic radiation therapy, something like that, right? And we know that there's a stage migration with PSMA PET, therefore, some unknown larger number of lesions should be allowed, right? And that's sort of how our mindset was for a long period of time, right? Especially in the initial staging setting, was that there was stage migration, right? And so I think the point of this article is to point out that, hey, it's not always stage migration upwards, it can be stage migration downwards. So, sensitivity, definitely it's more sensitive than bone scan, right? So there's issues with bone scan, both on sensitivity and specificity, but it's the specificity side, particularly in a population where you have a low pretest probability of having osseous mets. So when you're talking about initial staging, when there's not a lot of bone mets, you're much more likely to have false positives than you are to have true positives on the bone scan. And so, in this paper we looked at is, hey, actually, when you have 1, 2, a few lesions seen on a bone scan, that's actually unlikely to be prostate cancer. It's more likely to be something else. And so the trials that we used, conventional imaging, bone scan, and CT, that showed low volume bone mets was actually, the low volume patients, you're treating localized disease more likely than not, rather than patients who have osseous metastases. And so that changes now that we're using only PSMA PET. So an osseous met with PSMA PET is very different. One osseous met is very different than compared to a single osseous met in a bone scan, right? Because it's much more likely to be localized with a bone scan rather with PSMA PET.
Yeah, great. And this is actually a great segue, I think, to talk about the actual study, right? And maybe Dr. Hope will stay with you. Can you just summarize for us the methodology of this study and the design and sort of what you guys did there?
Yeah, well, thankfully, there's a group of us who've worked together for many years in the PSMA PET world. So Jeremy and I have worked together on lots of projects. So we came up with this idea and put together a group of academic sites to pool cases, because there's not a lot of cases with bone scans and PSMA PETs that were done near each other, right? So each of our own institutions, we only had a handful, well, more than a handful, but maybe 30 or 40 or something like that. But when we pooled them across multiple institutions, we got up closer to 200 patients who had a paired PSMA PET and a bone scan. And then we did something which hadn't been done before, which is blinded readers. So we had 3 blinded readers for the bone scans and 3 blinded readers for the PSMA PETs, who had no idea of the outcomes or anything, and determined whether or not there was osseous metastases or not, right? And so I think that was sort of the methodology that's sort of strong about this. It wasn't prospective in any way, but we did blinded reads of them all. And then we compared the results of the bone scans compared to the PSMA PET to see how many times when we called disease on a bone scan, we used consensus reads. So, 3 readers, 2 of them called it positive, that was considered positive. And then we compared that to the results of the PSMA PET to see how often those were true positives.
Yeah, great. And I also should step back, and probably something I should have mentioned in the beginning is that both of you, of course, have been instrumental in getting PSMA as an imaging modality approved in the staging of prostate cancer patients. So of course, you've been working on this for a while, and probably better suited than anyone to design a study like this. And maybe Dr. Calais, I will also ask you, in this study, the PSMA PET was what was used as reference. Can you discuss why that decision was made, and whether there was another reference that was considered, like maybe biopsy lesions, for instance?
In studies like that, retrospective, where you try to look back at what happened afterwards, it's very, very hard to have confirmation, lesion validation of the positive findings, specifically in the recurrent settings. So biopsy was basically never available. And then the amount of work you need to put in to extract one biopsy sample in 200 patients, which takes you, months of work, is really is not the way to go to perform this study. So you need to play with the parameters you have in hands to find some kind of a standard reference. And here, because there was, let's say, sufficient level of evidence of the specificity and the positive predictive value of PSMA PET, we choose to use that way. So it's not exactly a head-to-head comparison with a, histopathology gold standard verification. It's more how bone scan performs in comparison to PSMA PET scan, and we take the PSMA PET as the reference standard, with knowledge that, of course, there are also many false positives on PSMA PET scan. So that's a limitation of the study, but in this retrospective study design, you cannot really overcome that limitation.
Yeah, that's a fair point, certainly. What is the false positive rate for PSMA PETs, and does it differ across earlier stage versus, I guess?
Yes, it does. It's the same with bone scan, and for any imaging test, that would be the case. You have to take into account the context, the prevalence of the disease, the likelihoods pre-test matters a lot when you have to characterize a lesion or not. And so I can talk about bone scan because that's what we're talking about here. Again, bone scan is non-specific for cancer. It is specific for bone remodeling. So if you have multiple causes of bone remodeling, But if you take a very advanced mCRPC patients with no metastasis, you will see a lot of bone metastasis on the bone scan very nicely because it does induce this bone remodeling. If you take a patient that has very early disease stage of prostate cancer with a maybe not so aggressive prostate cancer, if you see something on the bone scan, the likelihood of being a metastasis is much lower. And there is a little bit of the same with PSMA PET, but of course, PSMA PET, again, is much more specific towards prostate cancer cell target expression. But again, that's the same. For example, in the biochemical recurrent setting, patient with low volume disease, that's where you can have these false positives that we do see with PSMA PET as well. That can be an issue a little bit, the training. And, for example, the rib isolated metastasis is a common pitfall. There are some like that, but it's just less non-specific than bone scan. It is much more specific.